General anesthesia. It seems like magic, right? One minute you're awake, the next you're not. But it's not magic. It's pharmacology. It's a carefully controlled state. And the key to doing it safely is understanding the drugs that make it happen. So today, we're going to break down the fundamental rules of the game for both inducing and maintaining anesthesia. This is your playbook for a safe trip under.
Here's how we're going to do it. First, we'll cover the foundational code that all these drugs follow. Then, we'll meet the four big players for IV induction and the inhaled gases that keep patients asleep. And, to finish things off, we'll put you right in the driver's seat with some rapid-fire clinical scenarios to see how it all fits together. Okay, before we even talk about a single specific drug, we have to lock down two of the most important concepts in all of pharmacology: potency and efficacy. Getting this difference right is absolutely essential because it tells us exactly how to choose and dose these powerful medications.
So let's start with potency. Put simply, potency just answers the question, how much? It's all about the amount of a drug you need to get a certain effect. So the more potent a drug is, the less of it you're going to need to get the job done.
Now, this is so important. Potency is not the same thing as efficacy. The best way to think about it is with this key and door analogy. Potency is all about how well the key fits the lock. It's the dose you need to get any response at all. Efficacy, though, that's about how wide that door can possibly swing open. It's the absolute maximum effect a drug can have no matter how much you give.
Now, for the inhaled gases, the volatile anesthetics we'll get to in a minute, potency has its own special name, MAC, which stands for minimum alveolar concentration. This is the standardized measure. It's the concentration of that gas in the lungs where half of patients won't move when the surgeon makes an incision. It's the universal yardstick we use to compare these gases. All right, now that we have that foundation, let's talk about the intravenous drugs we use to actually induce anesthesia, to get the patient to sleep. We're going to cover four main players, and each one has its own distinct personality. The one you choose depends entirely on the patient in front of you. First up is propofol. It works by cranking up the effect of the brain's main inhibitory neurotransmitter, GABA. Now, this creates a really critical clinical trade-off. On one hand, it's fantastic for lowering the pressure inside the brain, but on the other hand, it causes major vasodilation, which can make a patient's blood pressure drop a lot. This is especially risky in elderly or unstable patients. Oh, and it almost always makes people stop breathing for a bit right after you give it.
Next, we have ketamine, and this stuff is in a league of its own. It works completely differently by blocking NMDA receptors. And you know what? It does the exact opposite of propofol to the cardiovascular system. It acts like a sympathomimetic, basically kicking the sympathetic nervous system into high gear. This jacks up the heart rate and blood pressure, which can be literally life-saving for a patient in shock. But that same effect increases the pressure inside the brain, making it a huge no-no for anyone with a brain tumor or a head bleed.
Then there's etomidate. Its claim to fame? Rock-solid cardiovascular stability. It's what we call hemodynamically neutral. It has almost no effect on heart rate, blood pressure, or how hard the heart is squeezing. This makes it the absolute go-to for patients with a really sick heart or who are just profoundly unstable. So what's the catch? Well, a single dose can knock out the adrenal gland's ability to make stress hormones like cortisol for up to a day.
And finally, we have the old-school barbiturate, thiopental. The key thing to remember about this one is that it's a powerful neuroprotector. It dramatically slashes cerebral blood flow, the brain's metabolic rate, and intracranial pressure. For that reason, it's been a classic choice for neurosurgery, especially when you're dealing with dangerously high pressure in the head.
So when you put it all together in a table like this, the key trade-offs just jump right out at you. Look at the stark contrast. Propofol and thiopental tank the blood pressure and the ICP. Ketamine does the complete opposite, cranking them both up. And then you've got etomidate sitting right there in the middle, just keeping everything nice and stable. This is exactly why your choice of induction agent is always dependent on the clinical context.
Okay, so the patient is induced. They're asleep. Now we have to maintain that state of unconsciousness. And that's where the volatile anesthetic agents come into play. These are the inhaled gases that the patient breathes for the entire surgery.
Now, all the modern volatile agents share some key family traits. In the brain, they do something really paradoxical. They uncouple blood flow from metabolism. What that means is, even though they decrease the brain's need for oxygen, they simultaneously increase blood flow by dilating blood vessels. Once you get above a certain dose, that vasodilation wins out, and you get a net increase in intracranial pressure. And this is critical. They also completely block the nerve signals we use to monitor the spinal cord, which means you just can't use them for certain types of surgery.
But even with those similarities, each of these gases has its own unique personality. Sevoflurane is sweet-smelling and doesn't irritate the airway, which is why it's the go-to for putting kids to sleep with a mask. Desflurane and isoflurane, on the other hand, are really pungent, and they'd make a patient cough and hold their breath. In fact, if you turn up desflurane too quickly, you can trigger this crazy surge in heart rate and blood pressure. It's pretty dangerous.
All right, we've gone through the concepts, we've met the drugs, now it's time to put that knowledge to the test. I'm going to throw 4 high-stakes clinical scenarios at you. Based on everything we've just covered, you make the call.
First one up. A trauma patient gets rolled in, they're bleeding out, and their blood pressure is circling the drain. You have to intubate them, and you have to do it now. What induction agent are you reaching for?
The answer is ketamine. For a patient who is barely hanging on to their blood pressure, you need a drug that's going to support them, not make them crash. That adrenaline-like effect from ketamine is an absolute lifesaver here.
Next scenario. You've got a patient with a brain tumor who needs surgery, and you know their intracranial pressure is already way too high. What are your go-to agents to get them to sleep?
You're choosing propofol or thiopental. Your #1 priority is to get that ICP down, and both of these drugs do that reliably. And the one drug you are absolutely avoiding is ketamine because it would just make that pressure spike even higher.
Okay, scenario number 3. A nervous 5-year-old needs surgery, and they are not letting you anywhere near them with an IV. You decide to put them to sleep with a mask and an inhaled gas. Which gas are you going to use?
That's an easy one, sevoflurane. Its sweet smell and non-irritating properties make it the universal choice for putting kids to sleep with a mask. Trying any other agent would just be a struggle for everyone.
And for our last one, a patient is on the table for a complex spine surgery. The surgeons absolutely need to be able to monitor the nerve signals from the spinal cord throughout the case. So, what anesthetic technique is mandatory?
The only right answer here is total intravenous anesthesia, or TIVA. As we talked about, those volatile gases completely wipe out the very nerve signals the surgeon needs to watch, leaving them totally blind to a potential spinal cord injury. So this last one isn't just about picking a drug, it's about picking the entire technique that makes a safe surgery even possible. It really makes you think, doesn't it? How often is the choice of anesthetic the single most critical decision being made in the entire operating room?